dive in. Let me start. Where are my video gamers at? Okay, wow, that's like the most ever. Help your friends that are not gamers, they might struggle this week with metaphors. Now moving on to this week's topic, we're talking about chronic inflammation, and then we're gonna kind of segue from that into healing that are related. So just kind of reviewing what we've been talking about over the last couple of weeks, the principles of immunity. So we talked a lot about hormonal barriers, your mucosal barriers, your skin, chemical barriers. So the first goal of your body is I want to keep stuff out, right? Infectious agents, foreign material, I want to keep it out of the body. But that's not always possible. Sometimes things get in, but if we can't keep it out, we need to be able to kill it quickly. That's acute inflammation, so that's everything last week. Couldn't keep it out, it got in, we have to deal with it right now. If I can't kill it, I need to somehow wall it off from the body to protect the body from the effects of whatever the thing is. So I need to sequester it. So if I'm unable to deal with it in acute inflammation, if I'm unable to kill it, I move into chronic inflammation, and the goal becomes not so much kill it, but damage control. I'm going to try to wall it off and protect everyone from defense. Ultimately, hopefully we can deal with it with this chronic inflammation, not always. But if we can't deal with it, we're then going to want to clean the area up and get back to work, resume the normal tissue function, whatever that function is for your tissue. So that's when we're going to move into repair. But repair and healing can really only complete after inflammation has resolved. Right, so repeated theme of this week. Chronic inflammation. Why do we go into chronic inflammation? Why do we progress from acute inflammation into chronic? Because it's a persistent stimulus. So if we cannot resolve the stimulus with acute inflammation, we then amp it up to chronic inflammation. Okay. So either acute inflammation is failing to get rid of the agent, it's something that the innate immune system can't deal with, or you have repeated bouts of acute inflammation that are kind of waxing and waning. Those would be like something like with an autoimmune disease. The nature of the inflammation is acute, but because you're in acute inflammation like this all the time, it ends up part of the inflammation. So what kind of things cause chronic inflammation? For pathogens, we tend to think of higher bacteria, so things that the body has trouble digesting or phagocytosing. So higher bacteria are things like mycobacterium, Rhodococcus, actinomyces, nocardia, things like that. So they have a really complex cell wall that the body has a hard time digesting. Usually it has a bit in it. Fungus is another one. Acute inflammation often fails to get rid of fungus. So we need to move on to different cell types, a different environment to get rid of fungi. Parasites, foreign material, including suture. So if you think about when you're suturing a wound, you want to generate inflammation in there because that's going to make things stick together, right? So foreign material in the form of suture and form of a grass on hydrating the tissue. Anything foreign, the body is not going to be able to digest that very well because it doesn't have an enzyme. There are also some unique virulence factors, specific organisms that live inside of macrophages. So these are things again like mycobacterium, tuberculosis, where the acute immune response just really doesn't have access to those bugs because it's intracellular, so we need a different mechanism to deal with those. And then just other mechanisms of like immune invasion. And then finally, many autoimmune diseases. So if you think about a persistent stimulus, not being something we can't degrade, but something that's always there in the form of self-antigen. So autoimmune disease by definition is going to be a chronic disorder or chronic inflammatory disease. Okay, so the downside of chronic inflammation, we have a persistent agent. So if that's some kind of troublemaker, then we're going to have ill effects from that continuing. You also get an excessive and prolonged post-response. So hopefully you learned last week that inflammation can be really damaging to tissue. Think about neutrophils, those little bags of digestive enzymes, they're just coming in and exploding the tissue. That's what pus is, it's liquefied tissue, so inflammation is extremely destructive to the body. So we really want to try to limit the, what we call the bystander effect. So that's kind of the damage to innocent, unaffected host cells that just happen to be caught in the area of inflammation. So this bystander effect is really a big clinical problem, and it causes the majority of the clinical signs that we see with inflammation, right? Another thing we're dealing with is that the damage from chronic inflammation becomes irreversible. So repair becomes more challenging. Often with these chronic inflammatory diseases, you're looking at a permanent loss of function in these areas because these lesions. If you think about a tuberculosis granuloma as like the classic chronic inflammatory lesion, they're big and space occupying, they're necrotic and destructive in the middle. So you've lost all that tissue, that's not something you could be able to repair. And then finally, we kind of hinted at this a couple weeks ago, but chronic inflammation is actually a major predisposing factor for neoplasia. So as part of chronic inflammation, you're creating these cytokines that increase fibrosis, that stimulate macrophage growth. So you're in this kind of proliferative soup that's stimulating cells. And that's kind of a selection pressure for cells to grow and start maybe becoming abnormal if they're dividing rapidly. You're also getting within these chronic inflammatory lesions, white blood cells can undergo exhaustion and become kind of immunosuppressive. So especially T lymphocytes, once they're dealing with an inflammatory stimulus for a prolonged time, they undergo what's called anergy, and they can not switch from participating in inflammation to becoming part of the problem. Now they're creating, again, more of these proliferative cytokines. They're secreting immunosuppressive cytokines. These exhausted leukocytes are like the quiet quitters of the leukocytes. They're like, this inflammation has been going on too long and it's time for you to go home. So they just sit down and they're like, I don't do this anymore. Screw you guys, macrophages on your own. Questions so far?
Did you say that process was energy?
Energy, like energy with an A. Like no energy. A is no.
But if I have this, that's different, just slightly. Like apoptosis, they're just sitting there.
They will eventually undergo apoptosis, but the leukocytes or lymphocytes respond to a lack of stimulating cytokines. So once the inflammation is done, they'll undergo it. Yeah.
And so, exhausted leukocyte, do they suppress other leukocytes?
Yes,
Okay.
they're secreting naughty things. As part of the role, if you think of a normal T cell, especially T helper cells, one of their jobs is to protect you from excessive inflammation, right? So you want them to be able to say, all right, guys, chill out, calm down. But that's inappropriate if we're not getting rid of this, right? That makes sense? All right, cast of characters. So acute inflammation, we're talking mainly about granulocytes. There's a little bit of macrophage action, a little bit of mast cell action. Chronic inflammation, we're talking primarily about the macrophages, the macrophage lines, the lymphoid lines, and these two guys, fibroblasts and angioblasts. A blast is something that makes things. It's also usually a baby cell, like a stem cell. So fibroblasts make collagen, scar tissue. Angioblasts make new blood. So they are going to be participators in chronic inflammation. Macrophages, these are my favorite cells. Macrophage literally means big eater. So these are from the monocyte cell line, they originate in the bone marrow, and we kind of think of them in two different categories. There are macrophages that live in the tissue, their assigned home is whatever tissue they're assigned to. So there's the Kupffer cells in the liver or the resident macrophages. There are alveolar macrophages in the lung. So most tissues have their own resident macrophage population. And then you also have inflammatory macrophages, which are circulating monocytes in the blood that can be called in during times of increased heat. hopefully you're doing this in immunology right now, so I won't go too deep into it. Macrophages, importantly for our discussion, are a major source of cytokines and growth factors. They can be either pro-inflammatory or anti-inflammatory, depending on the type of macrophage and the need. And their major role in kind of like the big picture immune response is they're an important bridge between the innate and the adaptive system. They are part of that innate phagocytic, right, immune response, but then they are also undergoing antigen presentation with things they phagocytose, so that's bridging to adaptive. Yeah.
When you're referring to macrophages, are you referring to both like the tissue resident, like, I know you might be different those, but are you referring to macrophages and dendritic cells? Or just macrophages?
I'm mostly talking about macrophages. We're not gonna go too deep into dendritic cells, but there's a lot of overlap. I kind of think of them as very extremely similar. That's a more advanced question. Yeah. Other questions? About my favorite cell? Anybody know this game? It's hard to 5 shots. So the goal of this game, these are both bad guys, and this is little sister, I think is her name. And if you see little sister and you annoy her too much, she'll scream and she'll call in Big Daddy. And then you'll have to fight Big Daddy. So little sister is like a neutrophil. She found some bugs that she's like, can't deal with it, takes help, and then she calls in Big Daddy. So big daddies. All right, so they're gonna come in a little bit later, so they are still part of that acute innate response, but after a couple days, they're gonna dominate the response, so that's when we're kind of switching from acute to chronic. And their presence in large numbers means that the acute inflammatory response has failed to take care of the thing. So Big Daddy needs to come in and take care of it. They live a lot longer in tissue, so they are much more persistent than say a neutrophil, which is gonna run in and explode and die instantly, quasi cells. And here's what we do with macrophage. So phagocytosis, we're doing intracellular killing of any organisms that we find. We're presenting in T cells and doing that bridging to adaptive immunity. Once we deal with the stimulus, they're also really important for debriding tissue. So if you think about the acute response and how much necrosis and damage that takes, that causes, think about pus and all the dead neutrophils and destroyed tissue. So one has to clean that mess up, right? That job's falling to macrophage. It's the quicker, cleaner effort cell. And they are the predominant cell in most forms of chronic. This is phagocytosis. Learn to know it. I have nothing really interesting to say about it. There's YouTube videos of it that are kind of fun. In little arms and their legs. All right. Another important thing we need to know about macrophages. They are susceptible to bacterial trickery. Some pathogens can actually survive inside the macrophage. They block maturation of the phag lysosome. No, the phagosome is this thing. So we've phagocytosed something, they are now in a phagosome. A phagosome fuses with a lysosome. Now it's a phagolysosome. Lysosomal enzymes are digesting the bacteria. Okay. So some bacteria can actually block that process. They can block fusion of those two structures. They can block acidification. So they fuse, but the lysosome doesn't have enough digestive acid to actually break them down. So they're just hanging out in here. They've turned the phagolysosome into like a little house for themselves, and they just continue to replicate the macrophage. Importantly, macrophages are able to re-enter the circulation from the site of inflammation, so they can pick up bugs and then travel to lymph node or systemically distant through the body. So this is a really common scheme that intracellular pathogens use for kind of widespread dissemination. Is in macrophages. These are kind of the classic characters. We doing this in immunology? Are we there yet?
Yeah.
Antigen presentation? Okay, so all this makes sense, and we don't really need to talk about it too much. Questions, let's do it that way, do you have questions about antigen presentation that are relatively simple and I might be able to answer?
So we learned that, I know that. You said we weren't going to go into like macrophage versus dendritic.
Yeah.
We did learn that like dendritic cells are the number one professional engine cell. So pretty much everything you're talking about with macrophages, we just applying that dendritic cells as well.
No. Dendritic cells are the best at antigen presentation, but macrophages are the best at phagocytosis. So when we're talking about inflammation, it really is mostly macrophages. Yeah, so that's kind of a confusing way to put it, I don't know if that makes any sense. They're similar but different. They're like fraternal twins, macrophage and dendritic cell. Other questions? Yeah.
About the process in the slide before, where the macrophage is like, you think the pathogen? Is that forever, the macrophage cannot,
Until it dies,
and then is it? Release it these contents when it dies and then it's bad again?
and then what happens after this macrophage dies and explodes and releases its contents?
Oh, but another one comes.
A cleaner upper is gonna come and eat the contents and become infected. Yeah, that's the strat. That's how TV literally works. Not a lot of these bugs work. Question. Alright, TLDR, macrophages eat stuff and present it to the T cells. Once antigen presentation occurs, the T cell then feeds back pro-inflammatory cytokines onto the macrophage that activate it. An activated macrophage has a lot of differences between a non-activated macrophage. Their metabolism increases, they become even better at phagocytosis, they get better at killing intracellular pathogens, they get better at producing cytokines. They also change their size and shape and become even more cool looking, as if macrophage wasn't badass enough, they become even cooler. They basically are bulking out. So here's what that looks like, and here's how we know it's happening in tissue. We see these two new forms of macrophages in tissue that are activated and pro-inflammatory. Remember, oid means like, so an epithelioid macrophage is a macrophage that has gotten so big and has so much cytoplasm that it looks like an epithelial cell. And that's this guy, they get huge, compared to like a blood monocyte or a resident tissue macrophage would look like this, they get huge. Those are epithelioid macrophages. And then I said the macrophage was my favorite cell, that's a lie, this is actually my favorite cell, the multinucleated giant cell. So these guys get so big and so aggressive and angry and frustrated that they actually will start fusing together into massive cells with a ton of nuclei. Very well, that's cytology. So when you see this, it kind of tells you that there's something the body is really struggling to get rid of. Phagocytosis is becoming kind of frustrated, and these cells are like starting to team up in weird blobs to handle it. They're not, the giant cells are not necessarily better at phagocytosis than an epithelioid cell. It's just kind of a morphology change that we associate with chronic inflammation. So when you see hulked out looking macrophages, that means we're dealing with something chronic. Here's what they look like in tissue. So these are, the multinucleated giant cells are super easy to spot because they're massive and have many nuclei. This is not even the biggest one I've ever seen, and they can get way bigger than this, especially in birds. Birds make the most insane giant cells. They're beautiful and easy to spot, yeah.
You said for the whole down macrophages, they're not better at phagocytosis.
But the whole count forms in general are better than like a regular macrophage. But a multinucleated giant cell, like it becoming a multinucleated giant cell doesn't make it better than a regular activated like epithelioid cell.
But the activated one.
But the activated ones are definitely way better at stuff than the non. Cool. Epithelioid macrophages are a little bit harder to pick out, but do you see all these big kind of bean-shaped nuclei in a sea of cytoplasm? Those are all epithelioid macrophages. They look like epithelium, they don't really look like macrophages anymore. Then we have a rim of lymphocytes, that's also really common in chronic inflammation. Spoiler, this is called granulomatous inflammation. It's the coolest kind. They look a lot like osteoclasts, right? Which are of the same cellular lineage, technically. Osteoclasts are also macrophage progeny, eating bone. All right, second major character is the lymphocyte. Hopefully you guys are also learning all about these in immunology. Just a little word about maturation and activation. Remember that their maturation is independent of antigens, so they don't need to be exposed to an antigen to mature. They do need to become exposed to antigen to become activated. Okay. And this is also important to know for our purposes in here. Which immune cells are capable of re-entering the circulation from the site of inflammation? So we need to keep an eye on them because they might be carrying bugs, right? So can a neutrophil re-enter the circulation after it's left? No. What about eosinophil? What about mast cell? Not sure, probably not. Macrophage.
Yeah.
Yes. T cell. B cell? Plasma cell?
No.
No. T cell, B cell, yes, plasma cell. Yeah.
We're saying T cell, B cell, yes, because they go through and then pop back into circulation.
Yes, they will drain, they can drain to the node and they can, so who can leave the site of inflammation is the big thing, it goes somewhere else.
That's.
All right, we got some more video game memes coming down, sorry about that. So skill tree in video game. So you start with a little level 1 character, and as you level up, you're allowed to choose a specialty. So my specialties that I can choose, if I'm a T cell, I can be a T helper cell. So that's like a healing cell or support class cell. I'm gonna stand back outside of the inflammation and I'm just gonna direct the inflammatory response. I make a bunch of cytokines and just send the troops out. Fine. I can also specialize as a cytotoxic T cell. This is like the melee class. So they are gonna go in there and get their hands dirty. They're gonna be stimulated by these Th1 helper cells to go into the site and actually directly kill infected cells by contact. I can also become a plasma cell. So if I'm a B cell, my only choice is to become a plasma cell. These are like the range damage. So they're spitting out antibodies and shooting them from afar. Antibodies are going to the site and causing damage. So the cytotoxic T is the only one that's really going in there. Natural killer cells also. Alright, so B cells, plasma cells. Again, I'm not gonna go super in depth on this, mostly just review from immuno. Plasma cells, partly know this is a terminally differentiated B cell. So once you're a plasma cell, you cannot go back to being a B cell. You are now a plasma cell. You die. You cannot leave the site of inflammation. You're now trapped. And your only job is to make antibodies. Cytotoxic T cells, melee class, this is the cellular hitman, is how I think of them. So he expresses CD8 on the cell surface, that's how we know he's cytotoxic. And his major job is to execute abnormal cells. Mainly for our discussion, this is going to be cells that are infected with intracellular pathogens. The cell cannot clear that infection on its own, so it needs to be told, hey, time to apoptose, you're causing problems. Also neoplastic cell, same thing. You're causing problems, I'm gonna give you an external apoptosis death signal and tell you get the F out of here. So how this works, this guy is checking all host cells. So every host cell except red blood cells, because they don't have nuclei, they have nucleated cells. All of your host cells express MHC1. If that is missing or abnormal, that is a signal for the T cell to kill you. So MHC1 is like your all pass.
have a question.
Yeah.
This sounds kind of familiar in terms of what I've touched on, I think, with natural killer cells. On previous slides. Same.
Yeah, same process, basically. There's also an NKT cell. Make it extra confusing. Is it an NK or a T? Yes. I kind of hate it. I'm really good at it because I had to take it so many times, but I sort of hate it. It also changes like every 2 years, so everything you're learning now is going to be irrelevant by the time you graduate. Just kidding, not the basic stuff. Learn the basics real well. Okay, diagram of cytotoxic T cell killing. It's pretty cool, but it's definitely melee class. They are getting in on action. So initial contact are joining up with the cell. They're kind of handsy, cytotoxic guys. They're feeling it up all over for MHC1. They don't see it. They're gonna form a synapse, which has 2 layers: the P smack and the C smack. Basically, it's getting ready to form a pore in the cell and spit digestive enzymes in the pore. T helper cells, so these are your support class. We mainly talk about them being Th1 or Th2, and it depends what kind of stimulation they're getting from the surrounding environment and the immune response. So a Th1 response is going to promote cell-mediated immunity. So that's what we want for killing of intracellular pathogens, killing of neoplastic cells. This is going to incite granulomatous inflammation, which I've already mentioned. We're going to talk so much about it. So granulomatous response is the classic Th1 response. If you think of the tuberculosis lesion, that is the classic Th1 cell-mediated immune response. A Th2 response is the other way. So this is an extracellular things. Extracellular pathogens, parasites. This response promotes humoral immunity. So when we want antibodies, we want a Th2 response. When we want cell-mediated killing, we want a Th1 response. That makes sense? These are not on-off switches. They're always present in some balance. They kind of have an inverse relationship to each other in many diseases. So as Th1 goes up, Th2 usually goes down, and vice versa. It's like a teeter-totter. Just a diagram of what I just said and some specific cytokines. These are highlighted because these came out of my notes, not because you need to memorize them. Please don't. I will never ask you to memorize a cytokine. All right, so T helper cells, kind of bringing it back into the context of chronic inflammation. These T helper cells are going to be the main players that are directing macrophages how to act in the tissue. So if macrophages receive a classical, so if you look at these cytokines back here, these are all Th1 cytokines for classical activation of a macrophage. This is the pro-inflammatory macrophage, the activated macrophage, giant cells, the epithelioid guys. These are the ones that are all right. Let's go deal with that persistent inflammatory stimulus. These cytokines, if you look at these, a lot of these guys are coming from T helper 2 cells. So how much macrophage activity do we want in a Th2 response? How much do we need them? We need them a lot. We don't need them a lot. We don't need them, right? Who do we need? We need B cells and plasma cells. Who do we need for a Th1 response? What? We need cytotoxic C cells and also. So if our T cells are producing Th2 humoral cytokines, this is like a hush signal on the macrophages. They're like, calm down, be quiet. They basically suppress macrophages. So these macrophages assume a phenotype of immune suppression and tissue repair. Because they're like, oh, I'm getting Th2, I don't need to go into overdrive to clear up some intracellular pathogen because it's something antibody mediated. Right? It's some parasite that I'm not going to be able to eat, it's too big for me. But what they try. Does that make sense? Okay, so we have different macrophage phenotypes depending on the T cell phenotype, the T helper cell phenotype specifically. Fibroblasts, so last couple of characters. Again, blasts are usually primitive cells, they might be stem cells, they're usually cells that make stuff, so like an osteoblast makes osteoid, which is underlying bone. A fibroblast makes fibrous tissue, collagen. So fibroblasts, actually, many of these blast cells that we're gonna talk about are mesenchymal. Remember we talked about epithelial mesenchymal tissues with metaplasia? So these are, bone cells, connective tissue cells. These cells are survivors, so they have really low oxygen and nutrient requirements. They're like the cockroaches of the cellular world. They can fibroblasts undergo metaplasia frequently. We talked about that a couple weeks ago. They're the main ones responsible for producing extracellular matrix. A lot of people kind of underestimate their role in inflammation, but they do actively participate. They can produce a lot of enzymes and growth factors. One cool thing they do is they will actually embed growth factors and enzymes and things into the matrix that they're laying down. So if something comes along and cleaves the matrix or digests the matrix, like an exploding neutrophil, that'll then release those cytokines and growth factors into the environment. So they actually do play a pretty important role in inflammation. But their major role is to fill in defects after tissue injury. So this is going to be one of the major cell types we're going to talk about when we get to healing and repair. Any questions? Yeah.
Could you go back one slide?
I suppose.
Yeah. So with the M1 and M2 phenotypes of macrophages, is that T helper one cells are like exclusively secreting cytokines that load the classical M1 pathway, and the other two is only doing M2 alternative, or is it kind of like you're both doing it balance of both, but one is more than the other?
So this is T cell differentiation. You are committed. You are a Th1 cell or a Th2 cell. You cannot switch. And once you are committed to that lineage, this is what you can do.
Okay.
What's happening is these pathways are doing this based on what's happening in the tissue, right? So I'm getting either more Th1 cells in the lesion or more Th2 cells in the lesion. That makes sense. So once they're there, they're committed. So once the number of Th1 cells go up, we're committed to a Th1 response. We're getting classically activated macrophages.
Okay, so not that each one is, they're always producing the cytokines they produce, but just more or less.
Yeah. Yep. That's the thing about a skill tree. You have to choose your choices carefully because you can't always go back and reassign your skill points. I'm mentioning it, but it often costs money.
Life lessons.
What?
Life lessons.
Yeah. Yeah. Other questions? Okay. Who in here has heard of Leroy Jenkins before? Yes. Oh, that's so many more than last year. Okay, so we'll see if this works. No, okay, so we'll YouTube it, I hope it still exists online. All right, so for those of you who have never heard of the legend of Leroy Jenkins. Have you heard of World of Warcraft? Okay, so this was, man, how many years ago even was this? World of Warcraft is a very, very old game. I've been playing it for a long time. So in World of Warcraft, what happens is you form these big groups and you go into these things called raids or dungeons and you fight like really big bosses that no one person could take. Maybe like 40 people sometimes. So this is an old, like this was even before Twitch, but this comes from the equivalent of a Twitch, an old timey Twitch video, like the 90s. And this was a big group of people in a raid. And they were all, about to go in and fight a big boss. And everyone's like, okay, I gotta take a potty break. I gotta get some chips. I gotta refill my drink, whatever. And they're all sitting there. Some people are away from their keyboard and they're talking about like the strategy for this boss. Like, okay, you go in and fight this guy. I'll go fight that guy. You make sure I stay healed. They're planning it out. And one of the characters who's sitting here in the raid waiting to get ready, his name is Leroy Jenkins. And he's away from his keyboard for this whole discussion. He's getting chips to drink out. And he comes back before anyone is ready Some people aren't even there yet, and he says, Leroy Jenkins, let's go! And he runs into the room with all the bosses, and everyone's like, what? And so people start following after him, and it's total chaos. That's the legend of Leroy Jenkins. You had to be there. But this is like Leroy Jenkins reimagined for modern times. And Leroy Jenkins in this scenario is a neutrophil. He's like, inflammation, all right, bitches, let's go. I don't even care, YOLO. He's gonna be dead in 5 minutes anyway, right? When this neutrophil. Like the ocean Fibroblasts.
Okay, guys. These guys give us a lot of trouble in the past. Let's put a little bit of this on here. One of these. Anybody need anything off the guards, or can we bypass it?
Yeah, I think Leroy might need something.
Doesn't he need body armor?
Yeah, that'll help him if it gets hot.
Christ. Okay, what we'll do is I'll run in first. Yeah, best. Yeah. And kind of just scare them all down and just showing our guys. Be in trouble if we don't do this quick. What do you think, Abdul?
Can you give me a number crunch real quick?
Yeah, give me a second. I'm coming up with 32.33, repeating, of course, percentage of success.
It's a lot better than we usually do. All right, guys. I'm on my way down.
Everyone, please, go.
All right, chums. Let's do this.
What was that, Joel?
So when he was like, I don't know, like a maintenance man?
Oh, he was like calculating
Yeah.
numbers and stuff, so he's probably some kind of T helper. Yeah, he might have been a cytotoxic T, we never really got to see him in action. Yeah. Neutrophil, something all that. I like the anthropomorphized inflammatory cells that helps. I don't know, that's the only way I made it through.